Patient is a 63-year-old male with a past medical history of hypertension, hyperlipidemia, type 2 diabetes, and stage 3 chronic kidney disease. He comes to the emergency department with a chief complaint of shortness of breath when walking for the past 10 days. There are no precipitating events. Rest makes it better. Walking short distances makes it worse. He has had prior episodes like this before, but it was never this persistent. He says that he can't catch his breath and says the severity is very severe. He wasn't able to leave his house for the past 2 days, and the timing is constant. He admits to swelling of the bilateral lower legs and orthopnea. He caught himself twice this week gasping for air and waking up in the middle of the night. He denies fever, chills, sweats, chest pains, lightheadedness, and dizziness. As for family history, his father is deceased at 70 due to a myocardial infarction. Mother deceased at age 74 due to stroke. For medications, he's on lisinopril 20 milligrams by mouth daily, metoprolol succinate 50 milligrams by mouth daily, atorvastatin 40 milligrams by mouth daily, metformin 1,000 milligrams by mouth twice daily, and aspirin 81 milligrams by mouth daily. He is allergic to penicillin, and his reaction is a rash. No social history documented. As for physical exam, he's alert, oriented, sitting comfortably, not in acute respiratory distress, but appears mildly tachypnic. He has an elevated blood pressure of 148/88, heart rate elevated at 102, and oxygen 91% on room air. No jugular vein distension at 30 degrees, but mild neck vein distension noted at 45 degrees. He is tachycardic, no murmurs, rubs, or gallops. He had bibasilar crackles upon auscultation, mild tachypnea. His abdomen was non-tender with mild distension. He had 3+ pitting edema of bilateral lower legs to mid-calf, no erythema, no warmth. As for labs, he had an elevated BNP serum at 780, elevated BUN at 34, elevated creatinine at 1.8, and sodium decreased at 132. Upon reviewing chest x-rays, his chest x-ray, he had cardiomegaly with pulmonary vascular congestion and mild bibasilar interstitial edema. Upon reviewing labs in his history, I came to the conclusion of heart failure. I would have this patient admitted. I would also have him referred to cardiology. For further workup, I would get an echo done. I would get his pulmonary wedge pressure and also his ejection fraction. For non-form treatment, I would have fluid and salt restrictions, diet restrictions, and have a more balanced diet. For farm treatment, I would put him on an ARNI and spironolactone for his edema. For follow-up, we'd have the inpatient team follow up with him as soon as possible to discuss his labs and the results that we've came to a conclusion to. And then for education, we'd educate the patient on what heart failure is, how to manage his symptoms and how to recognize them, and also diet restrictions. Thank you.